Good afternoon, everyone. That was a splendid start to the conference. Thank you so much for chairing the session, sir. Thank you for all the speakers. As a postgraduate, all these basic things form the base of our structure for the next, when we're going to become the future ophthalmologists and consultants. Now we're going to begin the next session, the session 2. This will be chaired by Dr. Chandrama Paul. She is a director at BBI Foundation, and she's also an immediate past secretary of Glaucoma Society of India. Our next chairperson will be Dr. Chandana Chakraborty. She is the leading consultant at RIU Kolkata. Would any of you be doing the postgraduate case presentation by any chance? Please let me know and give me your case presentations. Thank you for joining us, ma'am. Over to you, ma'am.
A very warm welcome and good morning to all of you. So I welcome my co-chairperson, Professor Chandana Chakraborty, and the moderators, Dr. Sholil Mondol and Dr. Ruju Unayat. Please come over to the dais. So our first speaker this morning is none other than Dr. Sholil Mondol. He's a professor at the Regional Institute of Ophthalmology, Medical College, Kolkata. And he's going to speak to us on evaluation of a patient with ptosis. Over to you, Dr. Mondol.
Hello. So the topic is the clinical evaluation of ptosis. Ptosis is not a tough at all. It is a very simple thing. If you understand and you measure it, it's a very simple procedure right now. And even you doing a surgery, a single drop of blood is not there. So no financial interest. Dropping of upper eyelid, its normal position at or below the pupillar margin due to any pathologic causes related to LPS are known as ptosis. Types of ptosis, it may be congenital ptosis with normal suprarectus function. It's called a simple ptosis with suprarectal weakness with Leber-Phimosis syndrome, and synchytic ptosis like Marcus-Grant jaw winking ptosis and the misdirected third palsy. So, aquatosis can be classified into neurogenic ptosis, myogenic ptosis, traumatic ptosis, and the mechanical ptosis. So, pseudotosis is nothing but the anophthalmia, microphthalmias, phthisis bulbi. These are the lack of support of the eyelid because the eyeball, the diameter is very less. Due to shrinkage of the eyeball, yes, support is not there, that may cause this lead to ptosis, that is called the pseudotopis. And the dermatocalasis here, this picture says the dermatocalasis here, the overhanging skin over the eyeball causes obscure vision that may leads to ptosis. And here, this is a blepharochalasis. It's a fluid accumulation in the preapnetic fat of the orbital septum over the LPS muscle may causes swelling of the lid and causes dropping. This is not a true ptosis. In both the cases, blepharoplasty is the treatment of choice. So congenital ptosis, the Berg states that 80% cases of ptosis are congenital. Sidney Fox says that 90%. In congenital ptosis, the developmental dystrophy of the LPS, not due to innervational abnormality, may be associated with the superrectus weakness. It may be blepharophimosis syndrome also. So blepharophimosis syndrome, very important. Just follow the cursor. This is epicanthus inversus. This is ectropion of the lower lid at the lateral part. This is bony deficiency of the orbital rim. This is telecanthus. The canthal distance between the two medial canthus is increased and short palpebral fissure and also ptosis. So blepharophimosis syndrome may be epicanthus inversus, ectropion of the lower lid, bony deficiency of the supraorbital rim, telecanthus, short palpebral fissure, and the ptosis. So Marcus-Gunn jaw winking ptosis is a 4 to 6% ptosis. The Marcus-Gunn jaw winking phenomenon may be unilateral, mostly minimal to exerted, cosmetically intolerable. The fifth cranial nerve may be misdirected to the third cranial nerve palsy that may cause it momentarily flick. Stimulation of the jaw moving mechanism send an excessive impulse to poorly innervated pelvis enough to momentarily lift the leaves. That is the muscles of masturbation, lateral pterygoid, middle pterygoid, and the vaccinator, and the masseter. These muscles are, when it's stimulated, that may be abnormal impulse, so to the third cranial nerve, the superior ramus. The treatment is disinsertion of the central part of the LPS, not only the disease part, now that the theory has been changed. Disinsertion, a resection of the 22 to 25 mm LPS to disable the ptosis, because Marcus can have a flick. To obscure that flick, you have to resect the LPS, then followed by a tarsopontalus link with the silicone rod. This is a Marcus-Gunn. This is a Marcus-Gunn ptosis. Horner syndrome, third nerve neuron at the superior cervical ganglion, C1, C2, C3 may be involved. Ptosis due to paralysis of the Muller's muscle. The question may be asked. This is a very mild ptosis is in the Horner syndrome. It's not a moderate to severe ptosis. Meiosis in ophthalmos and hormesis of the affected side and depigmentation of the iris. Examination of the ptosis. History of time of onset of ptosis, history of improvement or worsening, mental status, any bleeding tendency or drug allergy, or history of hypothermia may cause an anesthetic problem. Observation, unilateral or bilateral. Patient looks up, down, up, and eyelid exertion should be checked. Faint lid crease always signifies there is an attachment of the LPS muscle. The LPS muscle has 5 attachments: the skin, anterior part of the tarsal plate, in the conjunctiva, and the lateral horn, and the medial horn. Degree of ptosis also noted. Abnormal head position, tilt on the right or tilt on the left, or chin elevation. Why there is head position is to maintain the binocularity of the patient. Otherwise, the patient cannot see. So binocularity, due to maintaining of the binocularity, either left or the right, or head pin. Chin elevation means a both eye ptosis. Unilateral ptosis, the right side, there is a tilt of the head to the opposite side. Measurement difference in the lid height in the eye, the primary position indicates the amount of ptosis. So examination of ptosis, position of the ptotic lid margin with respect to limbus and pupil. Vertical corneal diameter, average covering by 2 mm. With the primary position, a diameter of pupil is also estimated. So 2 mm of the cornea normally covered by the lid, upper lid margin. So marginal reflex distance in the primary gauge, the light in front, light thrown into the cornea, and the reflex from the cornea to lid margin determine the MRD1. So MRD1 value is increase in lid retraction commonly seen in thyroid ophthalmopathy, and MRD1 value is decrease in case of ptosis. So MRD2 in primary gauge, light reflects to the cornea, to the lower lid margin, lid retraction. This is a picture. This is a picture, the cornea to lower lid margin. The MRD2 value is increased in case of Graves' orbitopathy or thyroid orbitopathy in lid retraction. It may be also seen in the reverse ptosis in Horner syndrome. MRD3 in the extreme up gauge. Mind that MRD3 when you measure is an extreme up, it's not in a primary gauge. Ocular reflex, not the corneal reflex to upper lid margin, is a rough estimation of the LPS muscle action. Palpable feature height measurement, it is nothing but MRD1 plus MR2, the value is, if you plus, then the PFH value is estimated. That is the palpebral fissure height, MRD1, MRD2 value plus. MLD is extreme up gauge distance for the inferior limbus. This is the inferior limbus to upper lid margin. Yes, also the LPS function is estimated. So ptosis may be congenital and acquired. There is one look you can identify it's a congenital ptosis. Lid of the ptotic eyelid is slightly higher than the normal lid in case of congenital ptosis. Lid of the ptotic eyelid is slightly lower than the normal eyelid. This is the basic difference. If you see in front of the patient have on torticollis examination, you can see. This is nothing but the dystrophy fails to relax the reciprocal innervation of that eyelid muscle. LPS has ability to relax in case of acquired ptosis. So amount of ptosis, dropping of upper lid 2 millimeter is a mild ptosis. Moderate ptosis, dropping of the upper lid is 3 millimeter is a moderate ptosis. Severe ptosis, lid drops 4 millimeter or more. So then most important is the levator function action. Millimeter ruler held in from the eye. The most important, you examine the patient and the head of the patient should be negotiated to the wall. Then one of the finger, just like a thumb, is applied over the brow to cut off the muscle action, frontal belly or occipital frontal belly's muscle. This frontal belly always help to lift the LPS muscle. So your intention to cut the muscle action of frontal belly or occipital frontal is from the LPS. The brow is immobilized by the thumb. Pressure negotiate any elevation of the frontalis muscle. Patient instructor look downwards. Here, patient looks downwards, and the millimeter rule is fixed with a 0. Now the patient looks in the next picture. Patient looks upwards, and the excursion of the lid is measured. So that is the estimation of the LPS muscle. LPS muscle is very important for the ptosis. Ptosis is basically the two muscles. One is the LPS and is the Mullers. Mullers is a very small muscle. It causes a mild ptosis. And only the LPS, whether you act, you should know everything about the LPS muscle. Normal eyelid goes excursion approximately 15 millimeter, 2 millimeter movement transmitted superior rectus muscle. The 2 millimeter eyelid moves considered no LPS action, but it is transmitted by the superior rectus muscle. Ptotic eyelid moves 2 to 12 millimeter. Poor LPS action moves 4 millimeter or less. Fair LPS action is moves to 5 to 7 millimeter. Good LPS action is 8 millimeter. So, examination, extraocular movement should be checked. Left gauge, right gauge, up gauge, down gauge. Redundant skin of the eyelid is very important. Bell's phenomenon is, again is a very important reflex that during surgery, if you got poor bells, the surgery become problem. There may be exposure keratitis when the patient becomes sleeps and eye is not closed. So grading of the Bell's phenomenon is good when 2/3 of the cornea disappear. Fair, 1/3 to 2/3 is disappear. Poor, 1/3 of the cornea disappear. When there is a poor Bell's phenomenon, what do you do? There is no surgery. You applied a crutch glass. Bell's phenomenon types, inverse Bell's phenomenon, that is upward and inwards. reverse valve phenomena, downwards, inwards, perverts, wandering in any direction may be go. Corneal reflex can be checked in all the patient, and also you do a eye spec test if you have a facility. Baseline measurement, eye spec applied for 2 to 4 millimeter, eyelid measurement, movement measurement, improvement 2 millimeter or more is a positive say. Basically the eyes back, but the cold temperature initiate the acetylcholine from the breakdown from cholinesterase that may cause improve the muscle function and improve the ptosis. Ptosis examination, photograph and drug testing, all the ptosis patient, if you do well, if you not do, you refer the patient to neurology to exclude myasthenia gravis before your surgery, surgical intervention. Choice of operation, LPS resection, plication, tucking of LPS, sling surgery, brow suspension, the ptosis, the material to be used in sling clip, muscle clip, bank sclera, homogeneous and autogenous first lateral. Recently, we use a silicone rod approach. One is a skin approach and this is a conjunctival approach. So, conjunctival approach and the skin approach. Advantage of the conjunctival approach, post-operative reaction is less, healing much faster, early result obtained, surgically anatomy easily identified. Advantage of the skin approach, exposure is good, maximum resection can be done, best usually done in congenital ptosis, better correction ptosis than the conjunctival approach. As for operative lid replacement, lid height measurement is better seen in the skin approach. Disadvantage of the conjunctival approach, maximum correction ptosis is not performed. Per-operative lid height replacement is not possible. A disadvantage also require a better surgical skill and good knowledge on the surgical anatomy. Surgical procedure, mild bilateral or unilateral ptosis, Fassler Sabet procedure, what is that? Tersectomy and molarectomy, or resection of the LPS 10 to 13 millimeter, either skin or conjunctival approach. Moderate bilateral unilateral ptosis, sleepy eye, the patient have a good LPS action or poor LPS action. LPS action is good, then LPS resection is 14 to 17 millimeter in case of moderate ptosis. Severe bilateral or unilateral ptosis, LPS action less than 4 millimeter or less, cosmetically bad, functionally severe handicap. This type of ptosis often needs maximum LPS resection of 23 millimeter by skin approach. But we recently not doing in LPS resection, we do is a brow suspension sling, what is a frontal sling by the silicone rod is a much more easier. Complication of ptosis surgery is very important, often given a short 10 marks question. You should memorize psychological upset, overcorrection, undercorrection, uneven position of the lid, ectropion, entropion, lid lag or exposure keratopathy, loss of eyelash, very important. Don't touch the eyelash of any ptosis patient, otherwise there is a cosmetic beauty. Poor eyelid contour, conjunctival prolapse, deformity of the lid, muscular imbalance, hemorrhage and infection. These are the point of complication of ptosis surgery. So now I just see how a spatial ptosis correction, it is a Marcus ptosis. So 3 approach, one is the skin approach and there is a conjunctival approach and it is the Whitnell's ligament approach. Here we did a separation of the LPS muscle from the Whitnell's ligament where the attachment to the conjunctiva is much easier, easy to separate. Here the conjunctiva is dissected, the LPS muscle is dissected for 25 millimeter and tarsofrontal sling is doing. And now see what is the reaction of the patient. Here the phenomenon is still there, but the action is cut off due to cutting of the LPS muscle. This is a frontal sling is given and it is adjustment operatively. Now see, with the movement, eyelid flick is gone. This is published in Surgical Outcome of Unilateral Marcus conjoining ptosis in novel Whitnell's ligament approach in South Korea. This last slide, this is BPS correction. BPS I have seen first to correct the superficial component of the telecanthus by double jet plasty. After that, the deeper component correction by transverse nursing is doing a drill, then close approximation of the 2 medial palpal ligament through the bony tunnel and tied down. Previously, the Americans are used a stainless steel ware. We are the first time used the novel 10-proline suture. The ectropine is corrected by base outflap from the upper lid transferred to the lower lid. Here, the palpable aperture is increased by canthoplasty. After that, the bilateral tarsophlantal is linked with the silicone rod. This is a two-stage correction of the BPS. This is surgical outcome epicanthus telecanthus correction by WZRC and is also published in a PubMed Index journal. Thank you. If you are interested in reconstructive surgery, you can attend in 15th March, Hall 1B.
Thank you, Professor Mondal, for a wonderful talk that was really informative, and I'm sure the postgraduate trainees have benefited from it. We'll move on to questions later on. We'll finish off the talks first. So we move on to the next talk by Dr. Chandana Chakraborty, Approach to a Case of Orbital Inflammation. Dr. Chandana Chakraborty is a professor at the Regional Institute of Ophthalmology, Medical College, Kolkata, and she is going to take us through Approach to a Case of Orbital Inflammation. All yours, Dr. Chakraborty.
A very good afternoon, chairperson, moderator, my dear colleagues, and my dear students. So for the next few minutes, I'll be talking on approach to a case of orbital inflammation. So I want an interactive session, so please participate. There are 3 images. What is the first image? Can I get an this thing? Pointer. Anyone want to volunteer? What is the first? The first image? Good, very good. This one? The first clue. Definitely this is an orbital cellulitis, subperiosteal abscess. Ethmoidal sinusitis, maxillary sinusitis breaking through in the orbital cellulitis. Next one, see what is this? A case of bilateral retinoblastoma. So sometimes a patient can come to you, a retinoblastoma patient, with a picture of orbital cellulitis. This one? Yes, true you are. So this can also come because the age group is almost similar, 2 to 5 years age group. All the 3 they can come with orbital cellulitis picture, and all these cases have been treated outside by a course of broad spectrum antibiotic. So what you will ask for in case of orbital cellulitis, you have to find out where is the source of infection, the tooth abscess. So now after giving the antibiotic proper, see the response, the patient is fine. So remember, in case of orbital cellulitis in pediatric age group, you don't have to, less than 9 years age does not need any abscess drainage in most of the cases. The reverse is not true, that is in adult you have to do the drainage. Another set of questions. What are these? All the age group, both these 2, they are 9 years, 11 years, and 3-year girl. All of them can come to you as a picture of orbital inflammation. See, what is this? We draw almost 10 cc of caseous pus, and the picture of the osteolytic lesion in the axial CT scan, the bone, that means, and the other patient, see, look at the nodule. The S-shaped notch you have already seen in the case, and see in this case, sorry, there was orbital venolymphatic malformation and sudden rupture, giving a chocolate cyst gives an appearance of proptosis with orbital cellulitis-like picture. So all types of lesions can come to you with orbital inflammation, so you must keep in mind to differentiate the diagnosis. So after the treatment with HET, this one came to be as a case of tuberculous osteomyelitis. The next one, the middle one, came as a case of tuberculous dacryoadenitis, and the last one we did aspiration and with the Kenacort injection, and the patient is fine now. So we'll a bit about inflammation. Inflammation, it could be an infective condition or it could be a true inflammation. In case of infective condition, you can get an, as I told, the orbital cellulitis, or that is the bacterial infection, the parasitic infection, that is a case of myocystis, or it could be an fungal infection like a case of aspergillosis or mucormycosis. This classification comes from the Rootman. The Rootman classified inflammation, the non-specific inflammation of the orbit. Non-specific inflammation may be again specific or non-specific. Now if we go to the non-specific classification, initially we used to call it as a pseudotumor, but nowadays the term pseudotumor is actually becoming, has become obliterated. Now we call it an idiopathic orbital inflammatory syndrome or non-specific orbital inflammatory disease. There are some examples. It could be, could be an diffuse inflammation, or it could be an localized inflammation. A localized IOIS can present with a case of, like a case of dacryoadenitis. It can present apical variety. It can involve the orbital apex or cavernous sinus, or it can involve a single muscle or multiple muscles. So these are the different varieties. And you should remember also that this thing may be combined also. So all these things may be combined also, or they can be. So now coming to the specific variety, as I told, we are diagnosing the case more and more, now the non-specific variety has come down, and the more and more we are diagnosing is, the specific has actually coming up. What are the specific lesions? Look at this. It could be, the most common is the this granulomatous variety, that is sarcoidosis. It could be Sjogren syndrome, Kimura's disease, then TD, IgG4 orbitopathy, idiopathic sclerosing inflammation, and granulomatosis with polyangiitis. As you do more and more diagnostic tools you use, the laboratory investigations you use, you will get more and more specific causes than the non-specific causes, that is the pseudotumor. These are the almost the similar age groups. See, in the left hand, what is this? Looks like orbital cellulitis. Yes. Again, the sinuses are involved. What is this? Inferior rectus muscles are involved. What is this? Myocystis. And this, you know, what is this? Thyroid eye disease. See, the typical sign of the Coca-Cola sign, the thyroid eye disease. Most of the muscles are involved. So after getting treatment, see the wonderful response. All the patients has improved. In case of this patient, this abscess, the ENT people, they did the drainage of this abscess. And remember, in all these cases, in this particular case, you have to, we have started using corticosteroid, both either systemic corticosteroid or Either it could be in the IV form, if you want to save the vision, or it could be in the oral form. Some more cases for you. Let's see what are these. All these cases are showing, see, the lead inflammation. All of the cases are showing lead inflammation. The upper one, see, this lady, she was treated as a case of orbital cellulitis, but no response. Again, the same picture. It is actually an dacryoadenitis. And the other one, bilateral dacryoadenitis. In the CT, how will you diagnose a case of dacryoadenitis? Because it could be a case of lymphoma also, bilateral lymphoma. So how will you see? Look at the picture. There is this lesion, the enlarged lacrimal gland, both the palpebral variety, palpebral part and the orbital part, there is a trailing lesion, trailing. It trails inside the orbit, not a very specifically means well circumscribed lesion. This is another patient, bilateral lacrimal gland in dacryoadenitis. In this you can see the coronal view, both the palpebral and the orbital part is involved. Another 25 years female, hyperintense lesion in T1 CT, showing that this is quite a long time the patient was suffering from this type of inflammation on and on. So there was sclerosing lesion. So after starting the steroid, look at the response. Within 48 hours, the patient responded. This also came to be a case of Sjogren syndrome, but the patient used to come to us once a year almost. Each time we started these anti-inflammatory drugs, but in Sjogren syndrome usually we don't treat it, we don't like to treat the patient with the corticosteroid. We usually try to keep the patient on just symptomatic medications. This is the coronal view of the lacrimal gland. And look at this patient. This came to be a case of, so this is a non-specific dacryoadenitis, this is Sjogren syndrome, this is non-specific orbital inflammatory disease. And this one a case of very rare, though I'm showing this case. This is a case of Kaimura's disease, which came only after the histopathology. This is for you, the diagnosis. Both the patient came to us with an inflammatory picture, and both the patient received corticosteroid outside. The CT is given to you. Anyone? Megha? What do you think? They received anti-inflammatory drug outside, and for the time being, both the patient was relieved after getting the corticosteroid. This is a clear-cut case of orbital lymphoma involving the inferior rectus muscle. And this one is a case of adenocarcinoma, lacrimal gland. So few things you have to keep in mind when you call it a, look at the age of the patient. Look at the age. In a 75-year-old patient, whenever this age group is coming to you, always keep in mind that this could be a case of malignancy. You have to rule out malignancy. So lymphoma is a very commonly seen patient cases which comes to you with a picture of inflammation. And believe me, these lymphoma, they can betray you, because when you are putting the patient on corticosteroid, they give a very good response, only to come back after a few months. So you have to keep in mind. And look at this CT picture and the MRI picture. The lesion has almost gone. This is a lobular variety. These are some one or two cases I will show you. 47 years male who came with bilateral proptosis, extraocular muscle restricted movement, lab investigations we did for tuberculosis, for sarcoidosis, everything came negative. So with oral prednisolone, the patient is quite happy, and he didn't come back to us. This is, we diagnosed it as a case of IOID, idiopathic orbital inflammatory disease, on the basis of the clinical presentation and the CT picture. Because look at the typical case. Many times you fail to diagnose clinically a thyroid eye disease and an IOID case, myositis. Both of them will give you an inflammation of the muscle. But look at this muscle, both the tendons, the muscles is quite irregular, and this is a nodular type of the swelling is seen. Another patient, this is the this patient came to us when the patient was already treated for almost 5 to 6 months outside with the oral corticosteroid, and then he came to us with a picture like this, PL negative, RAPD in the left eye, fundus disc edema, you can see, total ophthalmoplegia. And this was the CT picture. As you can see, there is a hyperintensilation in the MRI. It is going almost up to the orbital apex. So involving the superior orbital fissure and orbital apex will give you the clue that it is a case of total ophthalmoplegia with optic nerve involvement. So, but the patient improved with corticosteroid this time. But the vision we have lost just because we could not diagnose it before. So this is a case of, we call it commonly Tolosa-Hunt syndrome, painful total ophthalmoplegia. This is a patient which I saw in my clinical practice. See bilateral, this is a 40 years old lady. I didn't do the diagnosis. The diagnosis was done outside, means for 10 years the patient was suffering with granulomatosis with polyangiitis, which we previously used to call it as Wessner's granulomatosis. So look at the picture. The patient came with a vision of mild pain, and there is Cianca, Pianca, all are positive, high ESR. The patient improved with pulse steroid. Patient was already on rituximab. But when the patient developed this RAPD and vision finger counting, then you have to add on with the IV methylprednisolone on that. So this is a granulomatosis with polyangiitis. Another case scenario, 18-year female came with bilateral diffuse episcleritis like picture, bulging eye, PUK, peripheral ulcer, and there is bilateral diffuse orbital inflammation, as you can see. Kidney function. We thought this is also a case of granulomatosis with polyangiitis, but as this was the first attack, there may not be, the response may not be positive. Means Cianca, Pianca, they may be negative at the beginning only. In 30% of the cases only they become positive. So maybe in future the patient can turn up again with a full-blown picture. Only thing you have to say the patient that there may be a generalized involvement, that is the systemic involvement, like the kidney function and all this you have to test. This is actually, the patient was diagnosed with came to us admitted with the left eye orbital cellulitis like picture, and after 1 week the patient came with a similar picture in the other eye. And the patient told that I had an attack of similar attack 1 year back. But there was minimum pain, and the patient was not responding at all with the oral or systemic antibiotic. And see what was the picture, the lab investigation, the serum IgG was very high. So on benefit of doubt, we gave a diagnosis of IgG4 orbitopathy. This is a new diagnosis. For last 10 years, this is coming more and more to us, IgG4 orbitopathy. For this, you need biopsy actually. We didn't do biopsy as the patient responded because biopsy of an orbital muscle, extraocular muscles, is not a very easy thing. So if the patient responds well with the steroid, then you can leave it. Now, these are the patients, the orbital inflammation patient, they come to you with this pain, bulging of the eyeball, photophobia, watering, redness, dimness of vision, double vision, color vision defect. If the orbital apex is involved, the swelling of the eyelid and periorbital. Don't forget to examine the mouth, because there may be a septic foci or the nasal bleed, there may be the mucormycosis or the sinusitis, the post-auricular lymphadenopathy. Don't forget to do a detailed examination So I think I have taken extra time now. I'll just finish it. Do a good history taking. Don't forget to take the past medical history. The patient may not take out from his bag or bag the past medical history. Take out all the papers and ocular and systemic examination. Sometimes the patient it may be associated with scleritis, episcleritis, all these things, and in iritis. So do a good examination and imaging. Yes, this is most of the cases. The imaging we prefer is the CT imaging because it gives you a picture of the bony lesion also. But if you think that it is basically an orbital inflammation only, then you can go for the MRI also. Some of the patients we can do conservative plan. Even in case of idiopathic orbital inflammatory disease, not that always we will do an corticosteroid immediately. We can wait and watch because some of these mild cases, they can spontaneously resolve. And then medical treatment, like in the form of the steroid, as I told, corticosteroid, either oral or corticosteroid, intravascular steroid, or even you can give an intralesional injection if there is a tumor-like lesion or orbital inflammation, you can give that. Monitoring the disease course is very important. Tell the patient that you can have it in future also, so please come for the follow-up. Then surgery, if we cannot do the diagnosis, sometimes you may have to go for an incisional or excisional biopsy. HP, the immunohistochemistry, they are very helpful. Then if any of this treatment plan does not, sometimes you may have to go for an radiotherapy. Low dose radiotherapy in a case of non-specific orbital inflammatory disease is very helpful sometimes. So lab investigations, don't go for, give the patient a long list of investigations. First, do your clinical investigation, diagnosis, provisional diagnosis, CT, and then you ask the patient to go for all these investigation, CRP, ESR, a hemogram. Sometimes a child can come to you with acute myeloid leukemia with a picture of inflammation. So do, especially in the pediatric age group, do a good hemogram and CRP, ESR, they may be high in infection, thyroid profile, because among the orbital diseases, 60% of the cases of the orbital diseases are a thyroid profile you should do. Infectious foci, ANCA, PIANCA, ANA, serum AC to rule out sarcoidosis, though it is a bit rare in Indian subcontinent. Then IgG4 orbitopathy, don't forget to do IgG for the blood. This is already, I told, the treatment plan, the antimicrobials, corticosteroid, biologics. These are the, rituximab is a very good armamentarium. In our armamentarium, rituximab, methotrexate, cyclophosphamide, they have got a lot of complications. But rituximab is a better drug, which we are getting the response. So changes in visual acuity, these are the red flags. And remember that orbital orbit is actually a Pandora's box. Anything can come out finally. So keep a good rapport with all the multi-speciality department and your friends. So these are my references. Thank you.
Thank you very much, Dr. Chakraborty.
I've taken, I think I have surpassed the time. I'm sorry for that.
That's
Extremely
all right.
sorry.
I think that was a very informative talk. And please join me in the dais. And we'll move forward to the next topic. That's localizing the lesions made simple, to be taken up by Dr. S. Ambika. Dr. S. Ambika is a consultant and the head of the Department of Oculoplasty at Shankar Nethralaya, Chennai. Of neuro-ophthalmology. Actually, this topic, localizing the lesions made simple, actually doesn't speak of any subspecialty. So I'm sorry about that. Apologies. She's the HOD of neuro-ophthalmology at the Shankar Nethralaya, Chennai. Over to you, Dr. Ambika.
I can use this. Okay, good afternoon all of you. First of all, let me thank the organizers for this opportunity. Well, I am a neuro-ophthalmologist. Let me just make it clear. And I can make 2 disclosures. I don't have any financial disclosures to make, and I will stick to my time. And I know it's lunchtime, so we will try to make it as interactive as possible. I'm going to talk on localizing lesions made simple. And I'm missing my previous speaker who should have given an overview of optic neuropathies. So let me make as relevant to my talk the missing talk. See, localizing a lesion will always start with you talking to a patient. So neuro-ophthalmology is nothing but first start with a proper history taking. You don't have to think on MRI or CT or anything, and don't think about hi-fi investigations without talking to your patient. The most common complaint what you would encounter in neuro-ophthalmology clinic is vision loss. So vision loss can be of a bizarre nature, right from a refractive error to a brain tumor. So you have to know how your patient is going to start giving the complaints to you. A vision loss and followed by diplopia. And this is the conventional diagram which we all have seen in our med school. And I'm not going to talk theory as much as possible. It's up to you to read up that. And here you have to apply how your theory to clinic is the key what you have to take home. So we will try to make it as much possible as case-based. So this is the visual system which I am trying to separate this entire talk into 4 parts. I'm going to talk on the optic nerve and the disorders, the chiasm and the retrochiasm and the higher cortical dysfunction. So this is how we are going to decode the vision loss now. So let me go on stepwise and case-wise. So optic neuropathies, like if at all you're going to get a patient with a vision loss, first of all ask what nature of vision loss. Is it an acute? If it's acute, if it's painful or painless, if it is a gradual, is it a painless gradual drop in vision? Because this all is going to give a clue for what type of etiology you're going to see behind that optic nerve. Because at the end, you're going to end up seeing a pale disc and you don't know what is going to cause that. So you have to give the prognosis based on the way you elicit the history from the patient. So all optic neuropathies is going to have a dyschromatopsia. Apart from the vision loss, you also have associated features like squint, proptosis, redness, ICP signs. All those things have to be used cumulatively. So pupillary reaction is the key. So let me just get anybody telling what are the optic nerve function tests? Already I've told 2. Yeah, make it interactive. We all will doze off. It's neuro-ophthalmology. Pupillary function, yes. How brisk a pupil is. If it is going to be a bilateral dysfunction, you will see a sluggishly reacting pupil. Don't expect a relative afferent defect in a bilateral optic pathway lesion. If it is going to be bilateral, if it is asymmetric or a monocular optic pathway dysfunction, you can expect a relative afferent defect. And there's one more condition where you can't expect a relative afferent defect. When? When the visual pathway is involved in a retrochiasmal lesion. When the LGB, your pupil fibers have gone apart. So beyond a LGB lesion, if you're going to suspect a causative agent, you may not end up seeing a relative afferent defect. So the visual field loss, the optic nerve function test includes optic nerve vision, color vision, pupillary examination, and a visual field, and an examination of the fundus, the optic nerve appearance. So there are lots of other tools in our armamentarium. OCT is there everywhere. You take from ophthalmology to neurology, everywhere people talk on OCT. So OCT is going to show the structural changes. And then comes the neuroimaging of brain and orbit. Always ask for brain and orbit because you may miss some lesions in the way, in the orbital apex, in the superior orbital fissure. When you get up lesions in that position, you may miss the lesion if you get only a MRI brain and you do not get that of the orbit. So this is the type of lesions you can see. You can read it up in the textbook. Again, any LGB beyond lesions, your pupillary reactions will be normal. So don't get carried away with that. So let me go case-based. This is a 30-year-old female with a complaints of sudden painful drop in vision over a week duration. She had right eye grossly normal, left eye had a 2-meter vision with a relative afferent defect. So where do you think the lesion is going to? Just rattle, whatever you feel like. Shoot. What's the next thing you are going to see now? Fundus. See the fundus. So now you know what it is. Where is the lesion? Cortex? It's in the optic nerve. So what is the next investigation you're going to plan? We know like what type of optic nerve functions we are going to do. So what is the next investigation? Color is dropped, I have told. So what is the next? That's the last. Before that, don't give money to the radiologist. You do first. What's in your clinic? Perimetry. Yes, excellent. Perimetry. Do a perimetry first. So the right perimetry is normal and that of the left is washed off. Okay, that also the patient got it earlier. And don't think you need always an automated perimeter to get that. A simple confrontation test is also going to be very useful for you to pick the disease. So what do you see? Now we have the glorified MRI over there. You see a lot of black and white stuff over there. And what you have, the problem is in this region. You could see this is the axial, fat suppressed T1 flare images where you can see a grossly thickened optic nerve. So this is the condition what we are dealing with. So what we are dealing here is a optic neuritis. And to add more flavors to this, we have a lot of seromarkers which are coming up in the literature. So be very careful what type of optic neuritis it is. So you may have to get, according to the ONTT, you don't need that much of blood test. But if you suspect a atypical neuritis, you may have to do a lot of blood tests because still this type of disease are evolving in this part of the world. And that's the Mog spectrum disorder optic neuritis, what you're seeing over here, because they have some characteristic features which you can read in the literature. So this patient was treated with IV steroids and she recovered well. So this is a 37-year-old female, again with a history of drop in vision in the right eye, and now she had low-grade fever and headache. And the right eye is again having a moderate drop in vision. There's a relative afferent effect, color vision is dropped down, and the left eye is normal by all means. Do you think any other further history I have to ask in this patient? Sorry? Brilliant. Neck rigidity. Yes, exactly. And I'm going to give one more clue to you. The patient had, and she is living with her brother who is having a TB. So in our part of the world, be always careful. We have a lot of infective spectrum overlay because you're going to pump them with high-dose steroids, chronic immunosuppression. And this lady, she had, this is her fundus appearance. So she had a gross optic nerve swelling, and that's a perimeter showing a dense inferior field loss. SSOCT is showing a gross elevation. That's a granulomatous lesion over there. And that's the MRI. Here again the lesion is in the optic nerve, but here as you could see, it is not sticking only to the diffuse thickening of the optic nerve, it's more of a sheath enhancement. Here the disease is predominantly in the optic nerve sheath, which is very characteristic for a perineuritis, a granulomatous type of picture, which can be easily misdiagnosed as a Mog disease too. So go on with the blood investigations, and with the systemic history, we may have to add up other investigations also. So she was positive for Manto and gene expert, and her chest showed a lot of nodes. So she was put on antituberculous treatment along with steroids, and that's the results what you see down the line. So she improved in her visual field as well as in her color vision, and a good recovery of the fields also. So that's a granulomatous optic neuropathy secondary to TB. So we saw a lot of cases from our previous speaker. So this is a lady who was referred to us with complaints of painful double vision. So here it was painful double vision to start with, but in the meanwhile she started having a drop in vision also for 10 days. And her right eye vision was 6/9 and that of the left eye was 6/12. So what do you think this lady can have? Where is the lesion? So what are the potential differentials you would give up? Remember, she came with pain and this picture. Okay. Commoner. You saw lots of images from the previous speaker. Yes. Good. Thyroid is a good differential. What else? Red eye. So much of engorgement. All movements restricted. Pain. Very good. There could be a cavernous sinus pathology. So, thyroid profile normal, all the other evaluations were normal. I think it's not moving. There's some problem. Okay, got it. So this is the fundus what you see in her. So do you think still the lesion is in the optic nerve? Visual fields are normal. And now you go, this is the orbit, MRI. So you see significant thickening of the extraocular muscles, but it is not sparing the tendon like what you expect in a thyroid. It's also extending to the orbital apex. So you see a orbital apex crowding, that's a bilateral compression, and you see grossly thickened extraocular muscles. So this working diagnosis were there for us, IOID, myositis, TED, IgG4 disease. Her anti-TPO was slightly elevated. We got all the specialties into the loop. We put her on IV steroids followed by oral steroids, but we went ahead and did a muscle biopsy too, which revealed diffuse inflammatory reaction, and that was a sarcoid-related inflammatory myositis, what we saw, and she had a very effective recovery post-steroids, and that's a picture. There's a good resolution of all the soft tissue, and the vision also got better. So next, moving on to the chiasm, unexplained vision loss and a headache. Be very, very careful in such patients. They may come to you with 6/6 vision. All the optic nerve function test, what you see and talk may be normal, but always check for the visual fields, because early fields will start in a chiasmal syndrome, which will give you a clue to image these patients. Very, very few times, like you will see patients who are having raised ICP also with a chiasmal syndrome. That can happen when your chiasmal lesion is going to pump up and move on to the suprasellar segment, where it can compress the third ventricle and result in that particular presentation. So signs of chiasmal syndrome can be optic neuropathy, and the optic disc changes can vary from normal to temporal pallor to bow tie or band, and a papilledema will happen, as I mentioned, in suprasellar involvement, and the other features are seesaw, and if it is going to involve the parasellar segment, we are going to have syndromes of the cavernous sinus involvement also. So this is a guy who presented to us with a drop in vision for 4 years, and he had a road traffic accident 4 years back. So after that, vision dropped in the left eye, and you can see definitely he has a lot of facial asymmetry in the left side. His vision in the left side was 3/60, and there was a relative afferent defect, and the CT had multiple orbital fractures. So this is a visual field what you see, and that's the optic nerve head what you see as a photograph. Could you see something which is not very, very typical for this in the optic nerve appearance? For a 4-year-old vision drop, what should you see in the optic nerve? Pallor. But do you see an optic nerve pallor in that left eye? That's the first clue you have to pick. And you see the visual field, it's densely wiped off in the temporal segment. And that of the right also, you can see the superotemporal peripheral area showing some changes. So this patient, he had a CT orbit. Unfortunately, they did not escalate it cuts to the brain, and which we repeated on an MRI, had a significant cellular mass, which was the cause for the vision drop. So what you saw in that patient, he had a combination of causes. He had a road traffic accident, presumed to be a traumatic neuropathy, but his vision and optic nerve and fields were not going hand in hand. So that makes you clue to go ahead and probe on your neuroimaging, and you have to ask for more further neuroimaging and always prefer an MRI brain and orbit, because many times we may not get a proper adequate cuts. And that's a lesion, and this is post-surgery. The same patient improved and complete recovery of the visual fields. So this is a 41-year-old female. She was referred to us as a thyroid eye disease. She had ptosis, she had squint for 2 years with lid signs. So I'll see how you guys are picking up the lid signs. There's a drop in the right eye vision, and that of the left eye is normal. So is that the buzzer for me? No? Yes? Okay, what do you see here? 5 minutes, done. Okay, what do you see here? Quick. Is there something you see in the central photograph? Oh. Right, mild droop. In this side photograph, what do you see? What do you see here? The bell is going to go up. There's an adduction restriction, okay? And what do you see here? It's full. There's an elevation restriction over here. So there's a right side vision drop, and her adduction is restricted, and you could see, what do you see here? Single clue. That's a right third nerve with aberrant third nerve regeneration. You see an inverse Duane's and a pseudo 1 graphe, okay? There's a right side drop in vision. This lady is not having TED. So that's her fields. So that's a dense field loss, and again there's a SELA mass which has to be operated. She had a multiple cranial nerve involvement, and the lid signs were mistaken for thyroid eye disease. So, and post-surgery she had a good visual recovery. And retrochiasmal lesions, you have to always look in for incongruity of the hemianopia. If it is more incongruous, it is going to be a anterior. A more posterior lesion is going to have a congruous defect. And this you can see only in incomplete hemianopias and not incomplete hemianopias. So let me skip this theory. Okay, this is a guy who was brought to us with 6/6 vision. He had repeated falls. His wife told that he is driving in one direction, and I'm scared to sit next to this guy. So this is the visual field. What type of fields you are seeing over here? Dr. Chandrima is not going to give me 2 more minutes. You better say. What type of fields is this? You see only in one particular quadrant. It's only inferior defects, okay? So you see only in the right side inferior quadrant. So that's a right pie in the floor defects, what you're seeing. And correspondingly, this guy is having a huge lesion in the left side parieto-occipital region with a cerebral bleed. And this, okay, let me skip and I'll give you a, this patient is very common in all your day-to-day practice. An elderly gentleman brought by the son saying that having cataract, get him operated, and he's bumping into objects. His cataract is not matching with the visual acuity loss. So first thing you have to check, he's got a bilateral PL vision, fundus normal, VEP very mild delay in latency. You're not able to explain the vision. Do not think anything, go ahead, image him. That's a cortical visual drop. If you're going to operate such cataracts, you're going to have a very bad prognosis. So always explain, find out whether the cataract is matching to the vision loss, then proceed with your cataract surgery. So that's a cortical visual impairment. So I think I may not have time to cover for a diplopia. So let me move on to the last slide. So detailed history taking is very important in neuro-ophthalmology. Associated signs and symptoms like headache, ICP features, type of field loss, concentrate on that particular history also. Correlate the vision to the clinical features. Differentiate retinal versus optic neuropathy, and ask for MRI brain and orbit as and when required, because sometimes you will have incidentaloma and you may have some other ophthalmic disease. So always correlate the vision loss. Let me take this opportunity to invite you all for the 6th annual Indian Neuro-Ophthalmology Society meeting, which is going to be held at Shankar Netralaya, and we have a huge galaxy of international neuro-ophthalmology speakers visiting us. Hope to see you all in Chennai. Thank you.
Thank you, Dr. Ambika. That was indeed a great talk. Even I learned a lot from that. I'm sure the PGs definitely did. So with that, is Dr. Manju Bhate here? Is she here in the hall? She's not there. Okay. So then I'll move on to my talk.
From BBI Foundation, Kolkata. She is the Glaucoma Society Secretary. So Dr. Chandrima will be talking on intraocular pressure measurement and concept of target IOP.
Thank you, Dr. Chakravarti. Once again, a very good morning to you all. And in the next few minutes, I'll take you through intraocular pressure measurements and the concept of target intraocular pressure. So the importance of intraocular pressure is the main risk factor for the development and progression of glaucoma. Lowering intraocular pressure decreases the risk of progression. Protective effect of IOP is definitely dose dependent, and all stages of glaucoma, starting from ocular hypertension to early and advanced glaucoma, benefit from IOP lowering. But having said that, I would like to say in broad capitals that high intraocular pressure is not primary open angle glaucoma. There are a lot of other factors before you label a patient as primary open angle glaucoma. So the factors that influence intraocular pressure, you can see a lot of them that you have in our day-to-day activities that actually influence intraocular pressure. And because of these factors, when you measure intraocular pressure at your clinic, you need to be aware that under what circumstances you're actually measuring that pressure, because that pressure could actually fluctuate over maybe 10 to 12 millimeters of mercury. So making sense of IOP fluctuation on that note is nocturnal rise of intraocular pressure, which has to be on your minds when you're measuring intraocular pressure. That's the worst time of the day for health. As you know, overnight blood sugar levels rise, blood pressure, body temperature, and heart rate becomes slower, and eye pressure is at its highest. So factors that influence intraocular pressure, body position. If you look at, there isn't a point out here. So if you just look at these symbols which are there on the right, this shows the positions, and according to that color is here the scatter graph, which actually very clearly reveals to us that how the position of the body actually changes the intraocular pressure. Next come factors that influence intraocular pressure, the eye movements. So if you have a look at these eye movements that you see out here, we have a graphic representation which I'll show you in a moment's time, and how they actually change intraocular pressure. So these studies were all done in the Hamilton Glaucoma Center by none other than Professor Wenreb. And look at this, how it actually influences intraocular pressure. Look at this gaze and look at the IOP out there. Look at this gaze, look at the IOP out here. So the gaze of your patient when you're measuring intraocular pressure is very important. To get the optimum intraocular pressure, you must ask your patient to look straight forward, neither up nor down or either ways. Next, we have activity. You'll be surprised to know how activity actually influences intraocular pressure. Just look at that. Resistance training, any kind of band push-up or weightlifting. Look at the, could I have a pointer please, if there is one? But just look at this. The cursor out here is not working very well. So just look at this, where the intraocular pressure goes with resistance training. Next, we move on to walking and cycling. However, during walking and cycling, look how intraocular pressure actually comes down. That's 30 minutes post, 60 minutes post, and 120 minutes post. Next, we move on to meditation and yoga. So this is actually a pretty controversial thing, because meditation does improve intraocular pressure, but yoga, certain yogas actually do lower intraocular pressure, but there are other yogic exercises which actually are detrimental to intraocular pressure. And this is alcohol consumption, which lowers intraocular pressure. So the factors that influence IOP, seasonal pattern, that's very interesting. If you have a look at both of these graphs, I'm sorry, I'm just hovering around out here because the cursor is not working always. So look at this and look at this. So if you see that in mid-winter, there is a rise, and again, if you look at this mid-summer, there is a fall. That's almost about 7.1%. That's better, thank you. Next, we move on to the tonometer types. So the tonometer types we have, you all know, you'd get it in the books, internet, everywhere. Indentation tonometer, applanation tonometer, pneumatic tonometer, non-contact, and contour matching tonometer. So if I move any further, I would say we would concentrate on this, that is applanation tonometer. That's still the gold standard for intraocular pressure measurement. Pneumatic tonometers are when you have some kind of a corneal problem and you need to measure the intraocular pressure, and non-contact tonometers are really not that reliable, and definitely we don't use them to guide us in progression or disease at the glaucoma service. And contour matching tonometers, well, we did a lot of the DCTs say about 5-8 years back, and we have studies on those also, but somehow they have not lived up to the expectations that they came with. So use of tonometers, pneumatic tonometers, as I told you about it, useful in eyes with diseased or irregular corneas. Pneumotonometers and tonopen can measure IOP through bandage contact lenses, and tonopens are favored. Actually, the studies show that tonopen does compare very favorably with Goldman applanation tonometer. So the current gold standard, as I told you, is the Goldman applanation tonometer, and you know that it applanates the cornea and the measurement of force required to flatten a fixed area of the cornea. That's the principle on which it works. And Goldman and Schmid actually acknowledged that a variation of the central corneal thickness would influence the IOP readings, and almost using Goldman tonometer for about 50 years. After that, we started correcting it for the central corneal thickness, and it's the Goldman and Smith algorithm actually centers around the 520 micron. That is actually the corneal thickness at which the tonometer needs no correction. Otherwise, you'd have to connect it either ways. So this is again the same thing. And applanation tonometer on thin corneas would mean underestimation of the IOP, and thick corneas would result in overestimation of intraocular pressure. So that's actually a rough graph. We really don't have any proper algorithm where you can actually, by the rule of law or by mathematics, get an exact measurement of the IOP. But generally what we follow is 70 microns change in CCT corresponds to 5 millimeters of mercury difference either way. So measuring the intraocular pressure with the Goldman applanation tonometer, I'm sure you're aware of it in your clinics. You anesthetize the cornea. Fluorescent sodium is a prerequisite, remember that, because that only gives you the correct Myers with which you can actually measure the intraocular pressure. Slit lamp illumination, arm positioned at an angle to the observation arm and brought closer to the eye till corneal contact is made. A biprism within the tonometer tip splits the image as seen in the two semicircles that you see out here. And the height, you should adjust your slit lamp that the height of both these semicircles should be equal. And there's a dial on the side of the tonometer which is fixed at 1, and then you move on your slit lamp for the instrument, the prism, to touch the cornea of the patient very lightly. And this causes a movement of rings towards each other. These rings would be far apart when you're far away, and then there comes a point where the two rings meet. And this is exactly the end point. That is where the two Myers, the inner edges, meet, and that you multiply by 10, and that would give you the intraocular pressure. Well, the Goldman applanation tonometer needs to be calibrated, and at least once a month at your clinic, you should calibrate the Goldman applanation tonometer. Just a little bit about intraocular pressure and anesthesia. So chloral hydrate is the perfect anesthesia for measuring intraocular pressure. Halothane reduces it, ketamine increases it, and of course endotracheal intubation increases it. And on that note, I'd like to say that the Perkins handheld tonometer is the best that one can use as an ambulatory tonometer and under anesthesia for if you're actually examining a child under anesthesia or performing a trabeculotrabeculectomy. Next, we move on to target intraocular pressure. So target intraocular pressure, the American Academy says that the goal of treatment is to maintain the IOP within a range at which visual field loss is unlikely to substantially reduce a patient's health-related quality of life over his or her lifetime. The estimated upper limit of this range is considered the target pressure. That's from the American Academy, and the European Glaucoma Society says that the estimation of the mean IOP maintained with treatment that is expected to prevent further glaucomatous damage. So it's individual, dynamic, and a modifiable parameter. If glaucomatous damage occurs under these IOPs, then you need to actually shift your target IOP. But as a bottom line of target IOP, it's that pressure at which there is no progression. So these are the golden words for target intraocular pressure. So the rationale for target intraocular pressure is IOP is the only modifiable risk factor, as I told you, that affects the progression of glaucoma, though there are other lifestyle changes which you can advise to your patients. Different individuals respond differently to the same level of intraocular pressure, and necessity to establish the target IOP for every single patient that you treat in your clinic. So factors that influence target intraocular pressure are race. African Americans show higher prevalence of glaucoma than Caucasians do, and African Americans show earlier onset and progress to blindness more frequently. So the associated ocular and systemic diseases, these are actually more of book knowledge. You can read them up, but just to cover up, it's pseudoexfoliation, systemic hypertension, antihypertensive medications, and diseases that interfere with life expectancy will influence target intraocular pressure. And by that I mean that if a person is going to live longer, you need to have a lower target IOP than a person who's going to live shorter. So the risk benefit of treatment, the impact of treatment, and the quality of life needs to be taken into account. So again, baseline IOP, it is important that the first IOP at which glaucomatous damage occurred, you need to know that baseline IOP if possible. Central corneal thickness, I've just spoken to you about it, so you know about it. And a point here is that the eyes with lower corneal hysteresis are more prone to progression. That is in various studies which were conducted. Factors that influence target IOP, again, severity of disease. What we do, if you look at this on your left-hand side, age of disease onset, that's death and severe functional impairment, you would see that life expectancy and target IOP have a direct relation when you set your target IOP, and the greater the life expectancy, the lower the target IOP. The rate of RCG loss, retinal ganglion cell loss, age at disease onset, physiological loss of the RGCs. There are instruments now which can actually give you the RGC loss at that particular age due to age or due to disease. And glaucoma accelerates the rate of loss, and slow in most patients, but fast in a few. So estimation of target IOP, let us have a look at this. We actually estimate it on the severity of glaucoma, which we divide into mild, target IOP around 18, 16 to 20, recommended minimum reduction from baseline is 25%. In moderate glaucoma, it's around 14 to 18, recommended is 30%. And in severe glaucoma, it's to bring it down to around 10 to 14, and the recommended is 30 to 45%. So that's the buzzer. Yeah, just another few slides. That's if you look at this, safe sight years they call it, and this was devised by Anders Hale and Brandel from Allergan and Zeiss together. It's a very informative graph that they've done. So if the glaucomatous damage is early, higher target IOP. If it is advanced, then lower target IOP. If life expectancy is short, higher target. If it's long, then lower target. Untreated IOP, higher target, lower target. Additional risk factors, no risk factors, higher target IOP. Additional risk factors, lower target IOP. And rate of progression, if it's slow, higher target IOP. And if it's fast, then it's lower target IOP. So that's a very simple way to actually set your target IOP. So routine continual IOP monitoring improves management, enables sustained relays treatment, improves adherence to medication, and plethora of data, which is a deeper insight. So IOP is not conserved from day to day. IOP behavior at specific times on a given day does not improve meaningful information regarding IOP at a specific time. That I just showed you at the beginning of my talk, how actually activity and everything else can influence IOP. So glaucoma is perhaps more multifaceted and less understood than all other eye conditions, given the ocular, vascular, and neurological involvement that it has. Much confusion stems from glaucoma being neurodegenerative, having vascular etiology, yet only IOP being commonly discussed and treated. Thank you very much for your attention.
Thank you, Dr. Chandrima, for that exhaustive talk on target IOP, which is a very important talk, actually. And thank you. As we have some time, if any PGs have got doubt, we are ready to take up. Any question for the speakers? Or you want to move for the lunch? मेघा का कोई क्वेश्चन नहीं है तो मेघा कोई क्वेश्चन नहीं है anyone has got any सारे क्वेश्चन सॉल्व हो गया आंसर बस चलो जितना क्वेरी था यहाँ पे पीजी एजुकेशन में आके सब सॉल्व हो गया यस सो सेशन फीडबैक फॉर्म प्लीज फिल अप करो सेशन फीडबैक फॉर्म मिला ना तुम लोग का नहीं मिला नहीं वो पहले देना चाहिए बिकॉज आफ्टर ईच स्पीकर दे शुड फिनिश इट नाउ तो दे विल मूव फॉर द लंच चलो दे दो so close the session.
So if you have any questions, you can ask any of the speakers who are here. Neuro-ophthalm, glaucoma, and oculoplasty. 3 of us are here. And if you don't have any, then I think we can close down the session, though we have almost maybe 25 minutes left, but maybe you can have a quick lunch and then start the next session at 2, or else,
Leave it.
or else we close down the session. I don't think there are any more queries or anything. So thank you very much. Thank you to the speakers for the wonderful talks that you gave, and thank you very much for attending this session. Thank you. Over to the next session.
Thanks for patience hearing.
Thank you, professors. That was a myriad of cases, lots of things to learn from you. I just finished my post-graduation, and it was a revision of everything. This was a capsule of everything that they're going to ask you in the exam. So do keep a note of it and go through it once again. We'll start the next session at sharp 2 o'clock. So if possible, you can quickly have your lunch and come back by 1:50. Thank you.